Thank you. Thanks for the invitation. I just wanted to emphasize that I'm giving this talk on behalf of my colleague and collaborator in Bulgaria, Dr. Sirakov. We worked a lot together on, with these devices. These are my disclosures. I don't know if you saw my previous presentation, but I like historical reference. I want to start with acknowledging Dr. Serbinenko, who was the father of neurointervention, who first placed balloons in aneurysm, detachable balloons with his fellow. Then they described the first balloon-assisted balloon embolization of aneurysm. So temporary neck protection existed even before coils. And of course, coils came later with Dr. Guido Guglielmi attempting to electrothrombose the aneurysm by delivering electricity, and then the coil detached accidentally, and that was it. The history is changed since then. Again, Dr. Vinuela and my very well-loved Dr. Duckweller, who we have a very special relationship. But I was very privileged to be trained by those innovators, and I think that a lot of the slides here are actually courtesy of Dr. Vinuela. I just want to emphasize that really the flow diversion and neck protection has always been a target for really adequate embolization. And essentially, this is an example of one case, one of the first GDC treated cases in basilar tip aneurysm in UCLA in the 90s. The patient actually expired and had autopsy, and as you see from macroscopic view, you see the coils in the aneurysm that transform eventually to a complete scar with neo-intimal formation in the neck, which essentially shows that once you close the gate, you shut down the aneurysm and you heal the aneurysm. So when you think about aneurysms, you have to think also about how do you control not only intrasaccular modification, but also hemodynamic modification. When you think of a balloon-assisted coembolization, you're actually doing both. You're temporarily closing the gate and you're addressing the intrasaccular modification and the transformation of scar of the aneurysm. From stents, we evolved from balloons to stents, and then now we recently, about a few years ago, we introduced this retrievable stents, and the good old Solitaire was designed precisely for that. However, Solitaire, as you know the history evolved into a thrombectomy device, but using the concept of detachable, temporary retrieval and detachable stent was actually picked up by other companies, and Phenox, for instance, was coming to US. They have a very innovative company. They have two devices, Peak Canvas and Peak Conus. So they're essentially a variation of Pulse Rider, would provide temporal neck bridging, and they could be detached and left in place. And Peak Conus has actually Peak Canvas, I'm sorry, has a membrane that actually provides additional flow diversion in adjunctive coiling. But the difference between Peak Canvas and Peak Conus is that Peak Canvas, the microcatheter has to be jailed. And Peak Canvas, I heard it was undergoing modification, but I think it's a very good device. This is a case of my colleague, Dr. Sirakov, who presents very nice obliteration of a recurrent aneurysm in the basilar tip. Recently published a paper with example case problem, with barrel reconstruction device. Barrel is also a very, I think, innovative device, but also recently I heard that was not going to be marketed in the US, but it's very good for wide neck bifurcation aneurysm when the bulge portion of the barrel can really protrude into the aneurysm and completely provide support for additional coiling. I'm going to focus on the two most novel devices. The braided retrievable device, it's Comaneci, is currently FDA approved in the US. Cascade still not yet approved, but CE marked in Europe. I work with both devices. Comaneci is a temporal braid, collapsible braid put across the neck, and essentially has a handle that controls the radial expansion. And it's functioning essentially like a balloon, but has a hybrid technology between balloon and the stent, if you will. The only difference is, obviously, it keeps the parent vessel patent. This is a case report we published of a fenestration aneurysm when you actually have a loop and you don't see well where the neck of the aneurysm is, and this was an ideal example where you can safely deploy the device knowing that there's a parent vessel flow and safely put coils for about 5 to 10 minutes. The first experience was actually, largest case series was in Bulgaria with my colleague Dr. Sirakov, who showed that this device is actually very safe and then specifically used for, well used for ruptured aneurysms. And this is the data, and you see the average deployment time was actually about 15 minutes, and some patients even had 25 minutes deployment time. And when you think about X, Y, or X or cross stenting, this is an example how we can use two devices. We published this recently. Two crossed devices across the basilar tip aneurysm will provide excellent support during coiling, and essentially with no thrombogenic complications and leading to complete obliteration of the aneurysm. Recent cases with Comaneci, again, with my own practice, it's very useful for even small aneurysms, stabilize the catheter, again, similar to a balloon, but you have safe deployment for prolonged time. This is a recent case that I did again on a practically no neck aneurysm, this tiny little bilobe shaped aneurysm that ruptured. We did dual access and we crossed the aneurysm from one side into the dome, and from there deployed the Comaneci, which provided very stable scaffold. This is the other device called Cascade, and Cascade has again, similar to Comaneci, but more dense mesh. The thing about Cascade is actually has more thick braid. You can play with the braid. Similar to Comaneci, actually, you can expand the braid, partially resheath it, and protrude into the aneurysm. These are examples of how it's done. Again, similar paper to the Comaneci. We published a series in 12 patients. Very good results in ruptured cases with no thrombotic complications. Interestingly, because of the dense braid, I got a few more seconds, we observed in one case is temporal flow diversion and stagnation. So when you deploy this across the neck, whether we're dealing with something that is actually, maybe that's a future, I mean, leave nothing behind, even without intravascular embolization, I don't know if that would be something the company will be interested in pursuing, and that's doable at all. So this is in a video comparing the two devices. You see the Comaneci is bending while the Cascade remains straight. I'm going to move forward very quick. This is another case of a use of both devices together on dual axis. On the left P1 we have Cascade, on the right P1 you have Comaneci, and we successfully delivered both devices and we coiled the aneurysm, the basilar tip aneurysm. One thing to note is there's thrombotic complications can occur. Now distal embolization is a potential risk, and if you see a subtle thrombus, you should retrieve the device and pull it back out. With this, I'm going to say thank you very much, and this was me and my colleague Dr. Sirakov from Bulgaria. Thank you.